Much indeed. So when I was a boy, my mother used to say to me with monotonous regularity, "You behaved so badly, you will not be invited back." So to be allowed on the same podium twice in one morning is a real privilege. I should say, she said afterwards, "You will only be allowed back to return the cutlery you removed the first time you went." And that's an old Scottish phrase from the poverty-stricken East End of Glasgow. Now, with the wonders of Keynote and instant response, I've actually, again, slightly altered what I'm going to say to you on the basis of the conversations we had over coffee. So there's a little something different coming your way from what's in the title, but we're certainly going to deal with vascular comorbidity to start with. Now, I don't know how you get on with your local cardiologist. Professor Clemens clearly gets on extremely well if they'll do right heart caths, and I'm very impressed with that. My local cardiologists, until very recently, didn't speak to me. In fact, they regarded me as something of a subspecies. I looked after arthritic old ladies, and I was vaguely irritating in the corner somewhere, but they certainly wouldn't say good morning to me. And I have to say, when about 8 or 9 years ago, I decided to take the adventurous step of moving into the cardiology literature, I went with great fear and trepidation. And I often use this slide to illustrate how I think I felt. Although this is also a useful slide, ladies and gentlemen, if you're ever teaching medical students, and you want to tell the difference between a basic science student and a medical student, the basic science students will look at this and say, "Oh dear, this guy's stuffed." Whereas if you ask a medical student to describe the slide, he'll say, "This is a patient in an inverted position with a perforation of the upper area of the duodenum." And as usual, they'll miss the obvious. And I always feel that the scientists get it right. This patient's stuffed. So this is how I kind of felt when I went into cardiology, now nearly a decade ago. So why should I talk to you at all about cardiovascular matters? Well, this is a little chart that Jim Odell and I dreamt up to try and explain the current state of rheumatoid treatment. And in it we have a series of decisions that are made around the patient, and I hope most of you recognize this treatment journey. You see that we start with a conventional disease-modifying agent, we'll move then to a first biologic decision, and then to a second biologic decision. And these decisions increasingly should be driven by some measure, and I don't mind whether it's DAS28 or your own preferred measure of disease activity. It will be what it is, provided it's something. Because if it isn't, I'm going to argue that you're a blood pressure doctor who never measures the blood pressure, and I think that's a very dangerous place to be. But we make these decisions empirically, and we recycle empirically. And I think that's probably going to have to change. But you'll see that the whole treatment paradigm is drawn on the basis that our entire focus is the joint. Now, as a rheumatologist, that's a good place to start. But I think what you've heard from Tim and what I'm going to argue for the next 40 minutes or so is that we need a far more holistic approach than that. And just before we go any further, I'm going to step out the spotlight, and this is your next physiotherapy. I need to see a show of hands on people who routinely, that is, every time they come to see you in clinic, have a blood pressure and cardiovascular assessment performed at the same time as their joint assessment. Show of hands now, please. Can I have a show of hands of those who did that 5 years ago, routinely? It's a lot fewer, but it's still in there. I'm delighted to see so many. I am going to ask the reverse question because that can look embarrassing in about 40 minutes' time. So the issue is that rheumatoid is a systemic disease. Now, we all know that. You know, we were taught that. We were taught about bronchiolitis obliterans, and we're taught about nodules and episcleritis, and all the extra articular things that we almost never see now. Their frequency in our clinical practice is much reduced. But that, I think, has tended to take our eye off the ball, because in fact, the comorbidities of rheumatoid are still legion and clinically very important. And I've itemized them here. Cardiovascular disease I'm going to talk about in detail. Infectious risk, both inherent in the disease and inherent in our therapeutics. And if the patient's life with disease involves therapeutics, then a therapy-induced comorbidity is a comorbidity nonetheless. Because remember where I started this morning was the patient in health. And the fact that they now have chronic disease does not mean we should practice apologetics for getting them as close to health as we can. Osteoporosis, I think, well recognized in this audience. Psychologic comorbidity, I'm going to come back to. And oncogenesis, which we've heard beautifully dealt with already this morning. And I don't know if socioeconomic decline is a comorbidity or not, but I'm going to give you and it's actually directly in response to a very insightful question I heard over coffee. I want to give you a direct proteomic approach to socioeconomic comorbidity, which is possibly controversial, but there we go. But let's start with the blood vessel. Now, the idea that we can learn from cardiovascular disease and mechanisms of cardiovascular disease in the rheumatic diseases and vice versa is now not a particularly novel thing to say. And what I want to do is quickly rattle through the key elements of data that you should have at the back of your mind when you're sitting talking to a patient who says, I heard that there was some problem with the blood vessels in people with arthritis. So I'm going to take you through a series of conundrums. Now here's the first, if you like, the first premise that Navid Sattar. Now you're going to hear Navid, the start of his name has kind of fallen off the slide here, but Navid is the professor of metabolic medicine in the University of Glasgow. And I'd love to say that some years ago I sat down and in a very insightful and clever way thought that we should look at cardiovascular disease, but actually what happened was that Navid ended up in the office next to me purely by chance. Secondly, Navid is a supporter of Glasgow Celtic Football Club. I, on the other hand, am a supporter of Glasgow Rangers Football Club. Now, those of you who know anything about soccer, that's, by the way, real football, not the ladies' game that's played out here with helmets and pads and, you know, and videos and all the kind of, I don't know what it's like. You see them all dressed up somewhere, nowhere to go, these footballers out here. So the real game, where real men stand up and get hit by each other, Rangers and Celtic are somewhat in opposition to each other. So by rights, Navid and I should never have talked to each other. But instead we started trading insults. And the insults started with the fact that Celtic almost never win at all. I mean, they won the odd football game. They don't play a game that I like. They're pretty terrible, actually. You're not hearing any bias in my assessment of this, whereas Glasgow Rangers are a fine football team who play in the Barcelona style with Brazilian influence. There aren't enough soccer fans in the room to know how far from the truth that remark really is. But there we go. And then, as one happens, we started trading insults about metabolic medicine and rheumatology. And as we traded insults, we became, as so often happens, good friends. And what you're about to hear is a story that actually evolved out of academic friendship. I'd love to say it was intellectually driven, and more recently, of course, it has been. But it really is driven by academic friendship. And that's just a kind of collegiate comment here, because it's something we all forget about in this mechanized, automized, omic age, that people talking to each other is where most good ideas start. And we drew this chart, and we published it in circulation a long time ago now. But you know, remarkably, it stood the test of time. There were almost no data to support this, but we stuck it out there anyway. And the idea we had was that your vascular risk increased over age, and then with the onset of some kind of autoinflammatory disorder, the slope of that risk was accelerated. And our guess was that cytokines or maybe other inflammatory mediators might drive that process. And I think the key discoveries of particularly the last 6 to 12 months in our place have been that it is cytokines and a whole lot of other things that drive that accelerated risk. So first up, is there increased risk of having a vascular event? And I think the answer now is unequivocally yes. We may argue about whether it's peripheral vascular, large vessel, cardiac function, but what nobody will probably really argue with, at least in rheumatoid, is that your standardized mortality ratio, your odds ratio of dying is increased, and it's increased something in the order of 2 to 3-fold over an otherwise matched individual. An important comment there is matched, because if you've really got to correct for things like smoking, hypertension, diabetes, and family history before you can tell the disparate risk, that is, what additional or non-traditional risk is accrued by having rheumatoid. And that's how the diabetologists have argued for preeminence